Now, if I combine all the extraoral and intraoral clinical features, we'll conclude the sign and symptoms. Dark brown staining of teeth, erythema, that is redness or inflammation of the mucosa, keratosis, that is the increase in keratin layer, and flaking surface. If you have seen the seepage paint that will pop up and then burst, it is very similar to the flaking surface. That's how a flaking surface looks like. Symmetrical fibrosis, marble appearance, limited mouth opening, burning sensation, stomatitis. This will be one of the clinical features in oral submucous fibrosis patient as well. Blanch, hard and soft palate, binding down of tongue, and another unusual thing you'll find in another unusual clinical finding you'll find in oral submucous fibrosis patient is shrunken uvula. The uvulas are constricted and short in size, very small in size, because of the involvement of lateral palatal fosses. So moving on to, if we from all the history, extraoral and intraoral findings, it was concluded that the patient has oral submucous fibrosis along with localized gingival hyperplasia. Causes of OSF. There are certain ingredients which you will take which can lead to OSF. Number 1 is areca nut or betel nut, number 2 tobacco, and number 3 betel quid. And if we talk about the pathology, the underlying pathology, the areca nut, in the areca nut or betel nut, there is an alkaloid component named as arecolin, which has the ability to induce fibroblast proliferation, collagen synthesis, which will cause the cross-linking of collagen fibers and leads to the stiffening of oral mucosa and fibrosis. Now, the standard treatments. First of all, you'll advise the patient to stop the causative habit. This is other than that, intralesional corticosteroids injections are given to the affected area, muscle stretching exercise or trismus screw. And if the condition is very severe and fibrotic bands got very thick and mouth opening get much lesser than the normal, then we'll go for surgical excision, wide surgical excision with the underlying buccinator muscle along with the skin grafting. But the progress and the consequences of this surgery is not very good, and prognosis of treatment is not good, and there are chances of relapse. Moving on to the treatment that we provided. Number 1, we counseled the patient to break the causative habit. That is very similar to the standard treatment. Also, it is the major factor to bring down the progressiveness of the disease. Number 2, tongue depressor muscle stretching exercises 3 to 4 times a day, very similar to the standard treatment. Then we provided the prescription to the patient, and prescription included tablet betamethasone 0.5 mg BD for oral ingest for 10 days. Basically, betamethasone is betamethasone, which is a steroid, and it can induce an anti-inflammatory effect for stomatitis in OSF patients. Tablet augmentin 625 mg BD for 5 to 7 days, which is an antibiotic for any underlying infection. Other than that, tablet Nordox, that is doxycycline 100 mg, and flagyl, that is metronidazole 400 mg BD for 5 to 7 days. This combination of Nordox and flagyl, this combination of doxycycline and metronidazole is best for to target gram-negative anaerobes. Other than that, we provided patient with the Renovate plus gel, which will also help in stomatitis. Tablet Subdex, which is multivitamin, which will cover the iron deficiency and other vitamin deficiencies in the affected patient. It will also help to improve the iron deficiency anemia of the patient. And lastly, the Clinica mouthwash BD for 7 days for overall maintenance of the hygiene. Then we referred the patient to the periodontal department for further evaluation. At the first visit they did the single arch scaling, and at the second visit they completed the scaling.